Hello and welcome. I'm Dr. Craig Barnett with Marshall University School of Medicine, the Division of Cardiology. And today I would like to discuss some of our recent cases, and particularly one case of coronary venous retroperfusion therapy for unstable angina. We have coronary venous retroperfusion available on protocol as a research device for patients who cannot receive other forms of therapy due to problems in transportation or contraindications to other medications. Let me briefly describe our setting in West Virginia. We have a unique blend of both rural and urban hospitals. Our VA hospital is truly a rural hospital in that it does not have a catheterization facility, nor does it have a cardiac surgery program. We have a full CCU and cardiology division, but the nearest invasive and interventive program is 2 hours away, even by air ambulance, in Lexington, Kentucky, and therefore limits the amount of therapy we can offer critical coronary patients. Our urban setting is with Cabell Huntington Hospital, and although being a major trauma center, lacks a cardiac cath lab and cardiac surgery program. This is available by ambulance 10 minutes away. Before we get into the case today, I would like to review briefly the technology of retroperfusion. Retroperfusion is a technique that gathers blood from a peripheral artery, and in this diagram shows the gathering of blood from a femoral artery, and via a computerized synchronized pump retroperfuses the blood backwards in the coronary venous system. The heart of this system is a computerized ECG synced pumping mechanism. This pump retroperfuses blood only during diastole and allows for normal venous drainage during systole. The catheter itself is specially designed to seek out and allow easy intubation of the coronary sinus ostium. The balloon is inflated during diastole to preclude any reflux of blood into the right atrium and is deflated each systole. The tubing then takes femoral artery blood through the pumping cassette out to the retroperfusion catheter. This case today is a case of a 60-year-old Caucasian male who presented with unstable angina of 2 hours of duration. He had previous coronary artery bypass surgery and angioplasty. The initial therapy and results are those of intravenous beta blockade, sublingual calcium channel blockers, chewed aspirin, and aggressive intravenous nitroglycerin and heparin until toxicity of nitroglycerin was noted. He had some mild decrease in pain, but for an additional 2 hours of observation in the hospital, he had continued pain. Retroperfusion was accomplished from the left subclavian vein and gathering blood from the left femoral artery. We had difficulty positioning the coronary venous catheter due to a double-barreled opening of his coronary venous anatomy, that he had a large opening to the posterior interventricular vein that the catheter continually hung up in. Prolapsing of the catheter into the right ventricle enabled the tip to come up and then enter the coronary sinus. Of note also, the coronary sinus had a wide opening during the silent area that narrowed and required placement of the catheter right here on the lip of this narrowed area to get a good balloon occlusion. The initial retroperfusion results were those of no pain and normalization of some nonspecific, or at least what appeared to be nonspecific, ST segments upon admission at a flow rate of 200 cc's per minute. Now, according to our protocol, our research protocol, we wean these patients from the pump at 4 hours. He tolerated this with a decrease of flow to 40 cc's per minute. However, after 3 hours of observation, he had acute onset of chest pain, identical to that of admission, that awoke him from sleep. At this time, as opposed to admission, he had marked ST elevation at this flow rate of 40 cc's per minute. He had immediate resolution in ST segments and chest pain with repositioning of the catheter and an increase in flow to 240 cc's per minute. He was eventually then weaned to no flow on heavy medications intravenously and oral, and was transferred for coronary angiography at the Lexington VA Hospital. He underwent successful PTCA to his circumflex occlusion of 80% and his left anterior descending saphenous venous graft of 95% stenosis. He is now asymptomatic at 1 month follow-up. We would like to review the ST segments of this patient. The ST segments on our protocol are monitored with the Myocardial monitor. This is a 12-lead ST precordial map and limb lead map that displays the ST segments over time. This is an example of a normal patient. This is an example of an anterior infarction that was not treated. Notice the marked change in ST segments over the anterior leads, the fluctuation of ST segments over time. This is our patient. He presented with minor ST changes on admission of less than 1 millimeter, but actually indicative of lateral ST elevation and anterior ST depression. This resolved with pumping. He tolerated a wean at 4 hours with very little ST change. However, after a period of observation, he had sudden return of ST segment elevation, indicative of both anterior and lateral ischemia associated with his chest pain. This resolved immediately with repositioning of the catheter, an increase in flow rates, and then, as can be seen towards the end of the graph, tolerated a wean from the pump without any ST change. In reviewing his echo data retrospectively, we can see that he had a markedly dyskinetic left ventricle that returned towards normal with maximum retroperfusion. Unfortunately, due to the abrupt nature of his recurrence of chest pain, we do not have any echo data to go along with the marked ST change. And at 1 month follow-up, he has a normally contracting left ventricle. So in summary, we have had the opportunity to treat a patient with unstable angina with coronary venous retroperfusion. I feel that this is a good case highlighting the management of unstable angina with this therapy.